you will restrict your presentation to 3 minutes so that you have time to discuss, and then we go on to the next group. Okay. Please start.
Okay, ma'am, I'm Dr. Pat, and I'll be presenting common drugs used for the hypertension and what are the safe antibiotics in the pregnancy.
So you are going to present exactly.
The antihypertensive drugs used are Methyldopa, Labetalol, Nifedipine, Hydralazine, AC inhibitors, diuretics. And the drugs in blue, I will be discussing those. First, the Labetalol. It's a first-line drug. It has a combined alpha and beta adrenergic blocker action. It can be used both orally as well as intravenously. In oral, it has a dose. We start with a dose of 100 milligrams twice daily, with which may be increased up to 2,400 milligrams daily. It can be given in hypertensive crisis intravenously, where we start the drug from 20 to 40 milligrams IV every 15 to 30 minutes till the response is reached. Just a minute. And its side effects are tremor, headache, asthma, congestive cardiac failure, liver dysfunction.
Are you able to hear me?
About the Methyldopa, it's a central acting anti-adrenergic drug which reduces the peripheral vascular resistance. It is safe for both mother and the fetus. It's not very effective in severe hypertension. The dose for the drug it can also be given orally. The dose, we start with a 250 milligrams 8 hourly. It may be increased up to 2 grams per day, depending upon the response. Intravenously, it can be given as 250 milligrams to 1000 milligrams infusion over a period of 30 to 60 minutes, but not more than 4 grams. The side effects are dry mouth, postural hypotension, hemolytic anemia, sodium retention, excessive sedation. Coombs test is positive in about 10% of the patient, and postpartum depression. Now, coming to the anticonvulsants, which are usually used are magnesium sulphate, diazepam,
Hello.
It is given in those patients who have convulsion during the pregnancy due to eclampsia, epilepsy, meningitis, cerebral malaria, tumors. The mechanism of action of magnesium sulphate is that it reduces presynaptic release of glutamate and blocks NMDA receptors. It enhances the action of adenosine, increases mitochondrial calcium buffering and blocking.
Dr. Ifat,
मेरी आवाज आ रही है?
Ma'am, you are not audible.
बेटे मैं तो बहुत जोर की बोल रही हूँ. डॉक्टर माला मेरी आवाज सुन रही है?
हाँ आपकी आवाज सुनाई दे रही है.
Ma'am, you are not audible.
Who is not audible? Am I not audible?
I can hear Dr. Radhika.
हाँ, और लोग सुन पा रहे हैं मुझे?
Yes, ma'am, we can hear you.
You can hear me. So I think something the matter with Ifat's this thing. So how does then Ifat interact with me if she can't hear me?
मैम का I think volume कम है लैपटॉप का, जहाँ इसलिए आपको सुन
Ma'am has come.
Okay, you can hear me now?
No, yes ma'am. ये है ना, यहाँ पर बंद कर दिया ना सब.
इफत मेरी आवाज आ रही है आपको?
Yes ma'am, आ रही है.
हाँ. बड़ी तेजी से चल पड़ी ना. हाँ.
ये वाला.
Okay, let's start with Labetalol. Come back to the slides, please. Can you do the first slide, Labetalol?
इसको टेबल पर रख दो फिर.
Can you share screen, Ifat?
Yes ma'am, I can hear.
No, you can hear all right. Show your slides again.
Yes ma'am.
Just a minute, ma'am.
Share screen करना.
Yes, ma'am.
Labetalol. इसको slide show में जाओ, Ifat, and the first slide, antihypertensives, and the two antihypertensives that you spoke about was Labetalol and Methyldopa. So you said Labetalol is a good drug for management of hypertension and in pregnancy, but you have, however, not indicated what is the BP at which we wish to start the antihypertensive drugs.
Ma'am, we should start the drugs to the, ma'am, am I audible?
Yes, yes, you are.
Okay, ma'am, we should start antihypertensive when the BP is more than 140/90. And at that time, we should start the antihypertensive.
Okay, so what is mild and severe? What is the classification of gestational hypertensive disorders?
Ma'am, it is mild, moderate, and severe. And in mild,
What is the cutoff values? Anything to do with the blood pressure measurements? Is it mild, moderate, severe? What is it like?
ma'am, in mild, it is about 140, 140 systolic up to 160, and the diastolic is less than 100. And in the moderate, it is 150 to 160, and the diastolic is less than 100 to 110, and more than 160, 110 is the severe hypertension.
Which body has classified it this way? Do you have a reference?
NICE is classified it.
NICE is classified. So the treatment of all the three groups of hypertension is the same. All of them are treated with antihypertensives?
No, ma'am, it's not treated as the same. If the patient has just gestational hypertension and more than one, we can we can give the antihypertensive to the patient and can manage the patient on the.
I was asking you at what blood pressure measurements do we like to start the antihypertensives? Your response was 130/90.
140 by
140/90. You want to stick to your response or you wish to change that? Is
Ma'am,
there anything that is...
in chronic hypertension, we can
So somebody who has first recorded 140/90.
No, ma'am, it's not like on the first reading we will start that. We have to repeat the BP measurement after
So it
4 hours.
it consistently remains at around 140/90. You still want to start her on antihypertensives?
Yes, ma'am. Please start.
Everybody agrees with that? There is a little girl whispering with you. She agrees with you? I think Aarti is speaking. Aarti agrees? So, these are the kind of questions that get asked. So mild hypertension, I don't think they require antihypertensive to be started. You can wait and watch. You can do a blood pressure monitoring, give her, some kind of anxiolytics if required, or, give her, basically modify her behavior patterns and also give her some kind of, a talk so that she is relieved of the stress in case it is there. And if it consistently remains of it, or it, comes at around 100, then one doesn't have to think twice. But I think it is better to wait and watch if it is around 140/90. Okay, Ifat?
Yes,
So
ma'am.
you have, yeah. Okay. So any other than the side effects that you have written here, the tremors, headache, asthma, any outcome in pregnancy? What is the effect of this drug on pregnancy, on the growth of the baby?
Ma'am, it causes mild this growth restriction, but it's not. If the dose is given in high doses, it can cause mild IgR.
So largely safe. Earlier reports
It's
said
largely
there was
safe.
oligohydramnios, but later studies showed that it is quite safe in pregnancy. Isn't it?
Yes, ma'am.
Okay. So now you have written intravenous 20 to 40 milligram IV every 10 to 15 minutes. Is there a rate or is it just given one bolus? How is it given?
Ma'am, we start with the 20 milligrams. That's what.
At what rate? How do you put it in saline? You put it in normal? Do you use it as you give it as a bolus in the syringe, or you give it in the form of a drip?
Ma'am, we give it as a bolus over a period of 2 minutes.
Yeah. So it can be given as a bolus over a period, in a short period of time, and doesn't need to be given as an infusion. So
Yes,
when you
ma'am.
are asked to write a prescription, it has to be complete in every sense,
Yes, ma'am.
right? Next
ma'am.
slide, please. Next, Methyldopa. So you had written intravenous Methyldopa. Have you ever given it? Have you seen it?
Ma'am, I have never given it, but I read
Is it available in India?
Ma'am, it's not available in India.
So I don't think anywhere in the world anybody is using Methyldopa intravenous now. because there are many other drugs, newer drugs which have come. Erstwhile, when we were very commonly using Methyldopa, even then the oral one was the formulation that was commonly getting used.
Yes, ma'am.
So, what is it? Is there any benefit of Methyldopa over Labetalol?
Ma'am, it is safe for both mother and fetus. That is one thing. And number two, it's very cheap and was initially available everywhere. So everywhere it was given, but now it's not available in India, so it's not usually given.
So why is it not available in India? Is it because of the side effects, or is it what is the reason?
Not, ma'am, one reason is that it causes postpartum depression, and the Western countries have decreased its use because of that.
Anything else? It is one of the safest drugs which had the longest, utilization. The number of years for which it was used actually demonstrated the safety of this drug.
Yes,
The
ma'am.
problem is the cost of the drug is so less, the production was costing more than the actual cost of the drug. So majority of the companies stopped producing the drug. That is the only reason. Otherwise, even now it is considered quite an efficacious drug. And like you've written, it is a centrally acting anti-adrenergic drug. So next, what you are going to talk about the anticonvulsant?
Yes,
Okay.
ma'am.
Yeah.
And the magnesium sulfate is the most commonly used regime, and the mechanism of action is it causes the presynaptic release of glutamate, it blocks the NMDA receptors, enhances the action of adenosine, it increases the mitochondrial calcium buffering and blockage of the calcium entry via the voltage gated channels, relaxation of the smooth muscle. So that results in the vasodilatation. We give it in the form of various regimes. And the most commonly used is Picard's regime. There are other regimes like Zuspan, Ciba, and low dose regime, also known as DACA. In Picard's regime, we give 4 grams of 20% solution. In that, 8 ml is mixed with the 12 ml of normal saline and given over a period of 5 minutes. And this is followed by 5 grams intramuscular 50% solution of this magnesium sulfate, and is given in each buttock. So total 14 grams is given as a loading dose. After that, we give 5 grams intramuscularly every 4 hours.
So, Ifat, can you tell me somebody who receives magnesium sulfate? What is the formulation? How is the preparation of the drug that is available? If you were, how is it available in your hospital? What percentage? How many ml? And how do you prepare a 20%?
There is a vial which contains 2 ml, and it contains a vial that contains 2 ml, and it has 1 gram of magnesium sulfate. So to 8 vials. 4 vials are mixed, so they contain the 4 grams, and that 8 ml is mixed in a 20 ml syringe. Where
what percentage solution is that?
Ma'am, for IV we give the 20% solution, and for the IM we give the 50% solution.
So are these 2 kinds of formulations that are available, or is it only one type of formulation that's available?
50% only available.
Yeah. So Aarti, you are absolutely right. It is only 50% that's available. You need to dilute it and make it 20%. This is a very favorite question that gets asked, because you should know how to prepare the solution. So I'm not going to go much into the depth because it's already 6:46. I'll just ask you one question per slide. So what do you monitor when a person is on? So you have already you have it there.
Yes, ma'am.
What is monitored? Just speak it out.
Yeah, ma'am. We monitor the NEJEX urinary output that should be more than 30 ml per hour. Respiratory rate should be more than 12. And if there is availability of facility.
So if earlier it was said you measure the urine output over 4 hours.
Yes,
and here you have written per hour. Which do you think applies?
Ma'am, per hour it should be 30, but we check after 4 hours so that we calculate at least it should be 100 in 4 hours.
So that's not a good idea. See, she could have actually given out a certain amount of urine in the first 2 hours, and actually it's gone into oliguria in the last 2 hours.
Yes, ma'am.
And the volume, if you measure at the end of 4 hours, would not actually give you an idea of what actually. Yeah. So It is
So
best
it
to
is
do it
always
every
better
hour.
to measure every hour.
Exactly. Next slide. So you've written antidote. So when do you give an antidote? Calcium?
Ma'am, when the patient we see there's magnesium toxicity, like the knee jerks are absent, and
So if the knee jerks are absent, you give her calcium gluconate?
no. Then we will measure the therapeutic. We measure the magnesium levels in the serum. If they are
No,
more
what
than
is the advice to the, now the lady is on magnesium sulfate and you find that the knee jerk is absent. What is your next advice? You ask for the magnesium levels, number one. Number two?
We will stop the further
And
dose.
hold the
further
next
dose.
dose.
Yes,
Okay, then after that,
and then if
you
facilities
give her calcium gluconate.
and
Do
then
you
check
give her calcium
output.
gluconate?
When the levels are higher, like more than 10 milliequivalents per liter, then we will
Anything else? Any other indication?
Respiratory
Ma'am,
distress.
when the
Yeah, so when there is
very less.
respiratory depression, it is not distress, it is depression. So you've written calcium gluconate 10%, 10 ml. Is there a duration over which it is given?
10
Or
minutes.
you just give it
Over 10 minutes.
Over 10 minutes
over
duration.
10 minutes? Okay, next please. Next slide.
When some antibiotics which we use in a hospital, and they are
So now you tell me a lady who is pregnant, 8 weeks of pregnancy, and her she has symptoms suggestive of urinary infection, right?
Yes,
And
ma'am.
on culture, we find there is E. coli, which is sensitive to nitrofuran. There is E. coli, right?
Uh-huh.
Now you tell me what are the drugs which can be given to this lady and what duration. Tell me the prescription. Say, for instance, you've written ampicillin here. In fact, you tell me what is the drug that you would want to give to this lady.
Ma'am, there are multiple drugs which we can give in this. One safe drug is cefixime. We can give 200 milligrams orally for 3 to 5 days. One is nitrofurantoin that is given 100 milligrams BD for 5 days. And ampicillin can also be given 500 milligrams 8 hourly for 5 days.
What about the alkalizing agents? Can they be
Ma'am,
given
in case of nitrofurantoin, the alkalizer should not be given because it works in the acidic medium, while the alkalizer causes the alkalinity of the environment. So it will not be effective. So in that
What
case,
about pregnancy? Are the alkalizing agents safe in pregnancy?
Yes, ma'am. Usually
First
they are.
trimester?
Yes, ma'am. They are safe.
Okay. So anything else regarding the ciprofloxacin? So if somebody, what about those group of drugs? The quinolones?
Quinolones are not given because they have effect on the adverse effect on the connective tissue. So later in the months, they can cause decreased bone growth, decreased muscle mass. So they are usually class 3 drugs. They are not given in the pregnancy.
So is it bone and muscle only or something else which is extremely important? What is it that is most affected? So it is the cartilage.
Yeah, connective tissue that I mentioned before.
Yeah, connective tissue. So importantly, cartilage, and that could be a reason. So I leave it to all of you to just go through the antibiotics because we have much more to cover. Is that all? Ifat, are you done with
Just
your
only the
Okay.
miscellaneous drugs, the
Yeah.
antituberculous, if the patient has tuberculosis, she has to be given, and antifungal like clotrimazole, we give you vaginal pessary if she has vaginal candidiasis, because that infection usually increases during the pregnancy, and if she has diabetes, that is also more common in the pregnancy. So we can give these antifungal vaginal pessaries.
Anything topical can be given. There is really no problem. But I think it is extremely important that you have highlighted that the anti-tubercular drugs can be given in pregnancy, even in the first trimester. And somebody who is conceived on ATT does not need to stop the anti-tubercular drugs in the first trimester, and it can be continued throughout pregnancy. Right. So next, please.
Yes, ma'am, thank you.
Ma'am, I am Dr. Vasindra. I will
Yeah.
be presenting on misoprostol, dinoprostone, and
Show your
carboprost.
slides, Vasundhara. Please show your slides.
New sheet.
So in the meantime, can somebody answer what are the various categories of drugs? What is category A, B? Who can answer? Vasundhara, can you tell me? Can you hear me? Aarti, Vasundhara?
Ma'am, category A drugs are those which are safe in pregnancies, and there have been studies done in humans also that show no risk. B drugs
B drugs are, ma'am, those don't have any control studies and conducted in humans, and there are only animal studies which show no risk to the fetus. C are, ma'am, there are no as such any control studies conducted in animals as well as humans. D are, ma'am, evidence of human risk to
So
the
where the risk overweigh the benefits are
Yes.
category D, where the category C is where the benefits overweigh the risk. However, there is limited evidence in the human beings.
Yes.
Okay, so you can give a very brief answer to such kind of easy questions. You don't have to, spend too much time on that. So let's have the slideshow, please.
Ma'am, misoprostol is a synthetic PGE1 analog. Misoprostol tablets are available in different doses, 25, 50, 100, 200 and 400 micrograms.
So can you tell us the Government of India guideline for the medical termination of pregnancy in the first trimester, Aarti? Is it Vasundhara, Aarti, whoever is presenting? Who is presenting, please?
Ma'am, Vasundhara.
Okay, Vasundhara.
Yes, ma'am.
Yeah.
Ma'am, can you repeat the question?
As per our country, Government of India guidelines for medical termination of pregnancy in the first trimester, what is the prescription?
Ma'am, in the first trimester, as per the FIGO 2017
मैं
recommendation,
गवर्नमेंट ऑफ इंडिया पूछ रही हूँ बेटे.
according to Government of India, ma'am, MIFI and Meso are used as combined. Firstly, we give the patient tab MIFI 200 milligram, followed 24 to
Till what period of gestation?
Ma'am, less than 9 weeks of gestation.
That is how many days?
For 49, 69 days, 63.
Right. So earlier it was 63. Now it has actually been brought down to 56.
56.
Yeah, because the failure rates were a little higher when they went, with each passing day beyond 56.
Yes.
So
ma'am.
what is the regime?
Ma'am, firstly, we will give tab MIFI just 200 milligram orally, followed by which after 24 to 48 hours.
Is it
we
24
will-
or 48 hours?
Ma'am, minimum duration is 24 hours. Or
No, I'm asking you the government. See, when you are living in the country of India, you should know your own country guidelines.
ma'am,
It's
48
important.
hours.
Yeah, so please learn. The idea of asking you this question is basically to get your focus back, because there are hundreds of agencies giving out various kinds of guidelines and advices, isn't it? So you
Yes.
should know about India. Yeah. Okay. So 48 hours. So 200 milligram mifepristone followed by
800 micrograms of misoprostol, ma'am.
what route?
Ma'am, either we can give the 800 micrograms vaginally or 400 buccally and 400 vaginally.
Okay. What is the success of abortion?
Ma'am, 90, less than 9, ma'am, less than 7 weeks, it's 80 to 90%, ma'am.
Only 90 only.
Less than 7 weeks, it's 95%, ma'am. More than 7.
We said 56 days, isn't it?
Yeah, ma'am.
Yeah. So it is less than or equal to 7 weeks. The success is 95 plus, 95 to 98%. So what is the advice? What do you tell such a lady? Somebody who's taken medical termination of pregnancy, what is your advice?
Ma'am, firstly, we will, when the patient come to us after prescribing the first dose, that is the tab MIFI gest, we will warn her about certain gastrointestinal effects of the MIFI gest, like she can have either nausea, vomiting, or diarrhea. There can be any contraction.
Common? Vasundhara, is it common?
Ma'am, it is not common, but
then why will you trouble her unnecessarily? Tell me specifically as a gynecologist what you wish to tell her now.
Ma'am, we will tell her about the bleeding and we will tell her when she has to report to us. There will be a cramping pain and she will have bleeding in 50% of the 50% of the regimens. Ma'am, we have to tell her about how much bleeding is like she has to report to us. Like we can tell her that if she is every 2 hours she has to change more than 2 periods, then she has to contact the doctor.
Or if she feels giddy, or if she feels
If
weak,
she
she
feels
starts
giddy
sweating,
or there is
or acute abdominal pain, then she has to report.
Yes,
Okay. So then she had nothing of the sort happens, and now she takes misoprostol. Then
Yes.
what is your advice?
ma'am, we have to counsel her and reassure her that after taking after MIFI, nothing has happened. Then after meso, there are 90 to 95%
That's
chances.
okay. We have already spoken. Vasundhara, what do you tell the lady now?
Ma'am, we will tell her about the bleeding patterns. We will tell her that there will be heavy bleeding for initial 3-4 days, followed by spotting. Plus, it will.
Why
it
do you
will
say that?
continue
Why do you
to
say heavy bleeding? Would you not want to tell her that she will expel something, which will be
expel?
a
Yes,
fleshy
ma'am. She
mass?
will.
And if she
Yes, ma'am.
doesn't expel, if she has only bleeding, she has to report.
Yes, ma'am.
And for what duration can she continue to have this bleeding?
Ma'am, 10 days.
What kind of bleeding? Is it excessive, the 10 days bleeding?
No, ma'am. Initially, it will be
Initial
excessive.
cramping, expulsion, followed by occasional spotting, which can persist for up to 10 to 14 days.
10 to 14
Isn't
days.
it?
Yes,
So
ma'am.
if she this lady reports to you back in 7 days, she says, I'm having irregular spotting. What is the next step?
She is having what, ma'am?
Irregular spotting.
Irregular spotting. After 7 days only, ma'am.
Yes.
Ma'am, we will reassure her.
And
And we
reassure her
will
to
call
say
her
what?
after 1 week.
Yeah.
Then we will go for an ultrasound to rule out any RPOCs.
Very good. So there is no need for DNC, no need for any kind of investigations. Wait for some more time, especially if she has given you the history of having passed out the products of conception.
Yes, ma'am.
Isn't it? Okay, next. How much time? We have only 1 minute left.
Ma'am, dinoprostone is a prostaglandin E2 analog. Dinoprostone gel contains 0.5 milligram of PgE2 in 3 gram of gel. Its indication is for cervical rightening and induction of labor. The route of administration is, it is
Tell
available.
me, Vasundhara, tell me one complication of using the dinoprostone gel. Okay, you are the consultant. You tell your resident to instill the dinoprostone gel on a patient, and she starts having acute abdominal pain, and the uterus starts contracting. What has possibly happened?
Ma'am, hyperstimulation.
Why?
Ma'am, excessive secretion of prostaglandins, which has made the myometrial musculature.
Any other answer? I don't agree with you on that. Any other answer? Here is the gel that you have inserted. I don't know why you are saying that there is excessive secretion of further prostaglandins. After installation of the gel, the lady starts having uterine hypertonic uterine contractions. What has happened?
Intrauterine installation instead of intracervical.
Intrauterine? Is it
Installation.
intrauterine?
Installation has occurred instead of intracervical, ma'am.
Okay, so intrauterine means what? Is it inside the amniotic
between the
cavity, or
membrane.
is it outside the amniotic cavity?
Outside the amniotic cavity, ma'am.
So there is a possibility of an extra amniotic
Extra
installation of
amniotic.
the
Yes,
drug.
ma'am.
So what is the basic precaution that one takes that such a thing doesn't happen? This kind of an adverse event doesn't take place.
Ma'am, we will assess the length of the cervix, and we will, during instilling the gel, we should be guarding the pointed nozzle tip.
Hmm?
Ma'am,
The
finger guided
nozzle.
installation we will do.
No. How? What is the basic precaution that you take? How do you ensure that it doesn't go in the extra amniotic space? You are after all going to push the drug inside, isn't it?
Yes, ma'am.
So you take the nozzle, reach up to the internal os, just come down below the internal os,
Yes, ma'am.
and while instilling, keep withdrawing your syringe slowly outwards, so
Yes,
that your pressure, because of the pressure on the plunger, the drug doesn't go into the extra-amniotic space.
जी ma'am.
Isn't it?
Yes,
Okay.
ma'am.
Next, please. Next slide.
Ma'am, carboprost is a synthetic prostaglandin F2 alpha. Each ampoule of carboprost contains PG F2 alpha 250 micrograms per ml.
So what
Indication.
is the Government of India and WHO guideline for the active management of the third stage of labor? What is the dosage of the PGF2 alpha to be given? Either it is,
F2 alpha is given 250 micrograms. It can be repeated every 15 minutes.
so this is therapeutic value. You have written here for the management of
Once, ma'am,
A22PA.
250 micrograms.
Vasudha, you did not hear my question.
Yes, sir.
Again, the Government of India has come out with a guideline for the utilization of carboprost. I will not use the word carboprost. It is prostaglandin F2 alpha
F2 alpha.
for the prevention of postpartum hemorrhage. Okay, one is the therapeutic dose, the other is the prophylactic dose. So I'm asking you, what is the prophylactic dose of prostaglandin F2 alpha?
Ma'am, 125.
Pardon?
250 तो
How many of you are sitting together? Anyway, you can tell me, all of you. What is the dosage? So it is 125 micrograms. Somebody had prompted, and yes, the answer is right. 125 micrograms intramuscular for the prevention of postpartum hemorrhage, whereas for the management, it is 250 micrograms.
Yes, ma'am.
Right. Next slide, please. Next. Okay. So tell us about DMPA.
Ma'am, I'm Dr. Nikita. I'll be speaking about DMPA. It is a long-acting reversible injectable contraceptive. It has dipomedroxyprogesterone acetate. It is given as 150 milligram Depo-Provera IM. It is to be repeated at 3 months interval. It is preferably given within 7 days of menstrual cycle. It can after
Okay,
abortion. It
Nikita,
can. Yes, ma'am.
Nikita, we stop here because I have to, we have to go a little faster.
Yes, ma'am.
People can read your slides, so you don't need to actually read your slides, but I will ask you the questions. Okay. So what is the specific advantage of DMPA? It is a hormonal contraceptive, isn't it?
Yes, ma'am.
What is the category of this hormonal contraceptive? Which category does it come into?
Ma'am, long-acting reversible contraceptive.
Very good. So what is the specific advantage in the postpartum period?
Ma'am, it can be given after 6 weeks to the lactating mothers.
Can it be given immediate post delivery?
Post abortal, it can be given immediately.
What about postpartum? Yeah, somebody is prompting. This is asking all the
Immediate
questions.
postpartum it can be
Immediately.
given, ma'am.
So you have written postpartum 6 weeks here.
Yes, ma'am, it was yes, ma'am. It might cause some irregular bleeding.
So
Ma'am,
what
it
is
is-
the Government of India guideline?
Ma'am, it is said that it can be given immediately after post delivery.
What is the Government of India guideline? Have you confirmed that?
Yes, ma'am.
Correct. So
Yes,
it is
ma'am.
after 6 weeks. This is what I'm telling you. It is important to be very clear. See, our government doesn't allow any of the hormonal contraceptives except for, there are anecdotal reports. Now we have Centromin, which is available, which can be given in the immediate postpartum period.
Yes, ma'am.
The progestogens can be started after 6 weeks, and the oral contraceptive pills once the mother has stopped breastfeeding,
Yes,
or
ma'am.
at least after 6 months.
Yes, ma'am.
But is there any advantage of using the progesterone only pills or the long acting contraceptive?
Ma'am, they can be given at 3 months interval. There is only single
Any
dose
other
that.
advantage? Any other advantage?
Ma'am,
Any effect on the
they do not
lactation?
alter. They do not alter the constituents or the amount of milk that is
So
secreted.
the quality of the milk is not altered.
Ma'am.
However, the volume of the milk has been found to be improved in some of the women. So that is why. So there is a question here. What is the dose of Dinoprostone Gel in a patient with PROM? So we don't prefer to use Kajal Baleja has asked this question. So we don't want to use the vaginal route of application of this, inducing agents, a person having premature rupture of membranes. Okay, Saheli,
Yes,
carry
ma'am.
on, please. Nikita?
Ma'am, it is a selective estrogen receptor modulator. It contains meloxifene, also known as centromin. It is a non-steroidal oral contraceptive, non-hormonal. It is available free of cost for women in India's Chaya under family planning
What is the
program.
mechanism of its contraceptive action?
Ma'am, endometrium receptivity, it decreases endometrium receptivity towards blastocyst signals. Also, ma'am, it is an estrogen antagonist in reproductive organs, so it causes hypoestrogenic environment, decreases estrogen, and it also makes endometrium unsuitable for implantation.
So does it inhibit ovulation?
Yes, ma'am, it does. Ma'am,
It
because
doesn't.
it decreases.
That is exactly what I'm trying to tell you. That it is, there are, I think there is the ormeloxifene, which is causing this kind of a confusion. Centromin is in fact considered a non-hormonal contraceptive, which was indigenously developed in India. And you have the L and the S isomers. The
Yes.
two of them have got different effect. The anti-estrogenic effect of centromin is much lower than the L isomer of ormeloxifene, right?
Yes,
So, what is one important side effect that this drug can have?
ma'am, it causes irregular bleeding.
Anything else?
Decreased women.
No, somebody's posted here hepatitis. I don't agree. I don't think there is any reports of hepatitis being a side effect of use of centromin. Anything else? So number one is ovarian cysts. Multiple ovarian cysts have been documented. Number two, some of the women were also found to have thickening of the endometrium and resulting in excessive bleeding during menses. So there is prolongation of cycles. There could be heavy menstrual bleeding. Some of the women also had amenorrhea. So these are the basic things which have been observed on long-term use of centromin beyond 2 years. Next, please.
Ma'am, next is Dinogest. Dinogest is an oral progestin 4th generation synthetic progestogen. It is used in endometriosis. It can be used alone in endometriosis, and it can also be used as contraceptive along with estrogen combination. It is used as 2 milligram daily oral given for 4 to 6 months.
What is the mechanism of action?
Ma'am, it causes moderate suppression of HPO axis and thus decreasing the GnRH secretion, which causes a hypoestrogenic environment, which causes thinning of which makes endometrium unsuitable for implantation.
So how is it better over one can even use DMPA, isn't it? Why Dinogest?
Ma'am, mainly it is used for endometriosis. It also has anti-angiogenic, anti-proliferative, and which helps in the decreasing pain during endometriosis.
Yeah, so the anti-angiogenic effect is very important. Number two, DMPA on prolonged use has been found to have effect on the bones. The osteopenia beyond 6 months of use continues 2 years of use, whereas Dinogest has been found to be quite safe even beyond 2 years of use. So, and the effect of its action, the metabolic effects are much better as compared to other progestins, and so are the systemic effects. Doesn't cause bloating, doesn't cause mood swings, isn't it?
Yes,
And
ma'am.
the anti-angiogenic effect of Dinogest
Anti-angiogenic action.
specifically has benefits. Next, please. So, yeah, who's going to present this quickly?
Ma'am, Dr. Khadija.
Yeah, okay. So I think we have another 2 minutes left and then we'll call it a day. I just wanted some kind of discussion on this because it's a very long list of drugs that we had to discuss today. Time is short.
Yeah, ma'am.
Yeah. Khadija, carry on.
Ma'am, TERBUTALINE, it is a category beta-2 agonist. It causes myometrial relaxation by binding with beta-2 receptors and increasing adenyl cyclase and decreasing intracellular calcium. Its role is to delay the delivery and provide the time for lung maturity in preterm labor. It is used for inhibition of acute preterm labor and for the management of the tetanic uterine contractions, or
Khadija, can you tell me any other drug which can be used for the management of preterm labor?
ma'am, calcium channel blockers like nifedipine can be used.
And
Magnesium sulfate, ma'am.
what is the
Retarded.
dose? What is the dose?
Magnesium sulfate, ma'am, 4 to 6 gram IV is given over 20 minutes. In 100 ml
Are
of
you sure? Over 20 minutes?
in 100 ml solution, ma'am. And then maintenance
20
dose is
minutes?
started.
I don't think one should ever give it at not more than 1 gram per minute.
Ma'am, then maintenance dose is given as 1 gram per hour.
Yeah, so I don't, other than the intravenous dose, can magnesium sulfate be given in the for repeated intramuscular dosages also?
Yes, ma'am.
What is the dose? Can 4 gram be given intramuscular?
Yes, ma'am, given.
Yeah, so you can give 5 grams, 50% sedation intramuscular. Isn't it?
Yes, ma'am.
Yeah, so in fact, that's considered safer compared to nifedipine. Why? Why? What are the side effects of nifedipine?
Ma'am, it causes refractory
It can cause hypotension, it can cause headache, it can cause the systemic side effects are much more. How is nifedipine used? What formulation?
Ma'am, it is used oral in oral tablet form.
What about
10 or
sublingual?
20 mg.
10 or 20.
Sustained release.
Okay, sustained release are available, yes, but I'm talking about the acute situation. Sustained release is not for the acute management.
Ma'am,
So
10
10
mg.
milligram or 20.
20 bolus, then 10 milligrams.
Bolus? No, I'm asking you, what about the sublingual formulation, the sublingual use of?
Usually
10
not,
mg. 10 mg.
10 mg, ma'am.
not given.
Can it be given sublingual? The
Ma'am,
No,
capsule?
ma'am.
No, ma'am.
Because
What
of
happens?
causes of postural
Sudden
sudden
postural
postural hypertension.
Is it only hypotension? It can cause to the extent that it can cause myocardial
Congestive heart
infarction.
failure.
Yeah, it can cause cardiac problems, so it is not to be given. So terbutaline, what is the route of administration?
Ma'am, subcutaneously it is given. 0.25 milligram is given every 20 to 30 minutes for up to 4 doses, or until the tocolysis is achieved. And once the labor is inhibited, it is given every 3 to 4 hours until uterus is quiescent for 24 hours.
So a lady who has gone into preterm labor, you have somehow managed to overcome the acute condition. You have managed to stop the labor. For how long do you want to continue the tocolytics? What
Ma'am,
route?
dexamethasone cover is done till dexamethasone coverage is done.
Meaning what? I don't understand that answer.
Steroid coverage is done, ma'am.
No, what period of time? 2 weeks, 3 weeks? What is it? Tell me how the steroid coverage is given. What dose with steroid?
Dexamethasone, ma'am, is given 4 doses, 12 hours apart.
How many milligrams?
6 milligrams, 6 milligram, ma'am. 6 milligram intramuscularly. It's given 12 hours apart, 4 doses.
Okay.
So till 48 hours, after 48 hours, we can stop, ma'am.
We can switch to
We can-
oral medicines and continue the oral tocolytics till delivery.
Is everybody in agreement with continuation of the tocolytics till delivery?
No, ma'am.
Yeah, should not be given. No need. The side effects of continuing these tocolytics longer in pregnancy have been not found to be beneficial. In fact, the side effects are much more, so better not to be used. So somebody had written here is isoxaprine, because now we don't use Ritudrin and all Duvedlan because of the side effects. Tachycardia is high. So we have, the better drugs which are of use, which are available today. We prefer to use the ones that we have just discussed. So why does Pallavi say magnesium sulfate cannot be used in preterm labor? It's not clear. Okay. So now I think, Dr. Mala, we are now, it's 7:15. I think I should stop here, isn't it? Dr.
I
Mala?
think, yes, we had a very nice program today. And it has been very fruitful. I'm sure all the PGs has nicely benefited from the program today. And we are waiting for the next day program Thanks, everyone. Thanks, everyone, for logging in today. And I'm sure tomorrow's program again will be very fruitful. Good night and goodbye to everyone. I thank all the PG students who have participated actively in this today's program. And I thank all the senior teachers who have given great inputs.
Ma'am, I would like to thank Mala ma'am and the organizers and all the moderators on behalf of all PGs. It was a very interactive session, and we had a glimpse of how we are going to be like performing in the exam. So, and how we are going to be questioned. So it was a very fruitful session for us, and we thank all the moderators and Mala ma'am for assembling this up.
That's very
And
sweet.
tomorrow
Who is the
and
one
day
who
after,
spoke?
we
I
have
think
2 another days of good interaction and good revision for all the EGPGs.
Yes,
examining
ma'am.
I
PGs.
must
Fantastic.
really congratulate the postgraduates for speaking out so nicely and thanking you, Dr. Mala. That's extremely sweet of that little girl who said that. Very nice.
Thank you, ma'am.
Thank you, Mala ma'am. And Radhika ma'am, it really reminded me of our days in
Thanks,
GT.
everyone.
Yeah, Tanya, so nice to see you.
I know, ma'am,
Yeah,
but
same
when we
here,
did
same
the
here.
ward rounds, how our
Yeah.
ward rounds used to be in the morning, and
Yeah, absolutely.
how you taught us, really fabulous. It takes you back to your old PG days.
Yeah,
And Mala ma'am, really fantastic. You're doing a lovely session. And thank you, girls. You've done a lovely job. You've got a
Thank you
really
so
Thank
much.
you, ma'am. Thank you so
So
much.
they're all
Thank all the
together.
PGs who actively
Thank you.
participated,
Yeah. Okay.
and we all really enjoyed.
Thank you.
Thank you, Dr. Mala. Thank you so much. Good evening
Thank
to
you,
all.
ma'am.
Bye bye.